Yes, we are live now.
Good evening, everyone. Good evening, delegates. Good evening, doctors, and good evening, speakers. I welcome you all for today's session regarding cervical cancer free in Northeast region by FOGSI, FIGO, and SAFOG. And I welcome Dr. Bhagyalakshmi Nayak, MD, FICOG, PhD. She's a professor, Department of
it's fine. Yeah, it's fine, Monica. I think.
Yeah. Okay, ma'am, I hand over the session to you.
Yeah. So a very, very warm welcome to all the dignitaries who have spared time from their very, very busy schedule to join us. Dr. Alpesh sir, Dr. Gokuldas, Ushasara madam, and Dr. Rishikesh Pai. So I request Alpesh sir for, can we have a CV of Alpesh sir? So I think he's no more unknown to the group in the Northeast. I think everyone knows him for the last 2 years. He has been on and off with them every fortnight, sir, talking about the cervical cancer prevention program. So, sir is the president FOGSI in 2020, vice president FOGSI 2013, governing council member of ICOG.
Dr. Bhagya, it will be okay. I think enough time I am introduced to this August gathering. This time we have Dr. Rishikesh first time with us. So you take double time to introduce Rishikesh.
Okay, sir. Thank you, sir. So really a pleasure, sir, to have Dr. Rishikesh Pai with us, who is the president of FOGSI 22 to 24, founder and medical director, Bloom IVF Group. He is the chief administrator of FOGSI Manyata Project, Group Society Liaison FIGO Women's Cancer Committee, editor, Indian edition of British Journal of OBGYN, editorial board member of Global Reproductive Health, board member IVF Worldwide, and many innumerable achievements, awards, 59 awards, including honorary FRCOG from the RCOG and the National IMA, MOGS, BN Purandare Award, Kanak Goel Community Service Award, delivered 700 plus lectures and 20 plus orations, editor of 17 plus books, contributed chapters in 60 plus textbooks. And past positions, he has been the past Secretary General, Senior Vice President, Deputy Secretary General, Treasurer and Chairman in various capacities, has been serving FOGSI for many years now, and I think he is a household name for most of the FOGSians. Past President, ISAR, IAG, Mumbai OBGYN Society and Maharashtra chapter of ISAR, Assistant Treasurer, Director Corporate Affairs, IFFS, which is International Federation of Fertility Societies, Adjunct Assistant Professor. But more than that, I think sir is an innovator and he gets brilliant ideas, and especially in the middle of the night, and a very nice person and a gentleman. Over to you, sir, for your welcome.
Thank you very much. I would like to first of all recognize Dr. Usha Saraya, our senior ICOG chair and FOGSI president, and Alpesh Gandhi, my friend and dynamic president, past president of FOGSI, is like a president. See, all the presidents are very active and they are doing great work, and I must appreciate. And of course, my great friend Dr. Gokuldas is here from the Northeast, Doyen, and then a lot of other people. Dr. Madhuri Patel, I don't know whether she's around or not. Dr. Priya Ganesh, I don't know whether she's there or not. I can't see her, but she's quite a dynamo. Bhagyalakshmi Nayak, her previous predecessor, and quite a famous person in the field of cancer. And then Dr. Sham Sundar, Ruchi Pathak, Seena Singhal, and Alia Aziz is our guest from SAFOG. And there are other senior professors like Dr. Panda, Burman, Meena, and Keshav. So, this is a fantastic project of the Northeast cervical cancer started by our great friend Alpesh Gandhi, dynamic president of FOGSI. And this project is going on at a fantastic, I know the Alpesh's ability, he'll do it very proper job. I don't know what he would have done had there been no COVID. It would have been difficult for all the next presidents to match him in his performance. Even with COVID, he could perform fantastically, I don't think I can match to his performance what he had done in his years. So it's a fantastic, and in the cervical cancer also, as we know, it's a big problem, and we are doing our best. This program of Northeast has been going on for the last 2 years. A lot of training of trainers has been done. So I am sure that from that angle, a perfect work is going on. So we need to have a synergy kind of thing. And, like when I took over the president of FOGSI, I said, what should I do? I was wondering, what can I do? How will it make an impact? And, in between, in confessional mode, I told Nandita, I really don't think I can change the direction of this country, or I don't think I should really get head up and say, oh, I'm the president of FOGSI and I have to do something, because I said, it's a 1.3 billion country. What can I do which will change the direction of this country? Only Modi and Amit Shah can do something to change the direction of this country as such. So I was actually confused. And even then I was confused till about 1-2 months back, when I actually saw a program on television where, this lady has if a meteor comes towards Earth, it can strike Earth and it can create a lot of problems. She did a research, and by just a small force, she has created an experiment which can deviate the meteor. Just by little tiny force, the meteor direction can be changed and it will miss the Earth. And then when I saw this, I was really taken aback. And then I said, yes, I know what I need to do as FOGSI president. And that is IEC. If I have to change the direction of healthcare in this country, I can't do anything on infrastructure. It's too huge. I can't change the roads. What I can do is I can do information, education, and communication. IEC, if I can do to the consumer, I will have achieved my goal. And that is my goal now. This is my goal is IEC. If I can advocate, you people are doing a fantastic job on the supply side. I have to do it on the demand side. I have to generate awareness. And last 3-4 days, I'm busy with the yatra, which is starting from Rishikesh, and I am obsessed. I can't sleep also. In the morning also I got up. I'm obsessed with creating that 12 minutes of information. If I can achieve that 12 minutes of communication with the patient, and I can make her retain what I tell her, I will have achieved my goal. That little small deviation in the trajectory of the meteor can change the direction of healthcare in our country. And that 12 minutes we are creating. I'm looking at all the slogans on the internet, placard, how to communicate, how to tell a patient. So, I made a slogan, cancer slogan. I said, test karo, cancer roko. Test. HPV karo ya pap smear karo, I don't care, or colposcopy karo, it doesn't matter. The patient should be told, एक test करो, बस एक test होता है, जाके डॉक्टर को पूछो कैंसर का टेस्ट क्या है, टेस्ट करो कैंसर रोको. This is my slogan for cancer for the next year, the whole year. Test करो कैंसर रोको. Like in family planning we have the slogan, हम दो हमारे दो, या पहला 2 बरस के बाद, दूसरा 3 बरस के बाद, means first baby after 2 years of marriage, second baby after 3 years of marriage. That is the government slogan. So like that, I'm classifying 12 important things right from menstrual hygiene. So I made a slogan for cup. Yeah. I just tell you what is that slogan. I just made that slogan for and then I'll shut my talk. As per, I made a slogan. तू पैड या कप कर इस्तेमाल, बन जाएगी तेरी जिंदगी कमाल. So this is pad or cup. So these are the things because my father was also into communication, and I feel that communication is the key to change. If you can communicate what is available where, you have made it. You can achieve the change, and that is what I want to do. And this will be complementary to what Alpesh is doing, because supply side is very important. Doctors should know how to do colposcopy, pap smear. Madam Usha sir has been doing a fantastic job for so many years, but I don't know how to do colposcopy. But for me, that you people are doing, I want to create interest in the patient side. They should come and say, "Arey, हमको वो दूरबीन लगा के देखते हैं ना, आप cervical cancer both करो हमारे." That will come only from communication. So I'd like to thank all of you, and I'm always there with you. Always there for any good program. And Alpesh, thank you from FOGSI for being so committed. Normally presidents after they retire, they don't bother, but he is a real committed person. And I really appreciate your enthusiasm. And I thank you all for doing this program. And I am there for you. Whatever help you need from the Federation, I'm always there for you. Thank you very much.
Very good.
Thank you, Dr. Rishikesh. Dr. Bhagya, can I take few minutes?
Yes, sir. Yes, sir. Sure.
So thank you, Dr. Rishikesh. First of all, thank you very much, Madam Dr. Usha Saraiya, our today's chief guest. You are always inspiration to all of us, and you are always there with this project from very beginning to guide us, to advise us, and you are always there in most of all the programs. So it is really inspiring to all of us. I am really thankful to my friend, FOGSI President, Dr. Rishikesh Pai. Today he is very busy. He has some batch, IVF batch at Nagpur. In between the batch, IVF batch, he is sparing some time for this program. It was difficult. I know it was difficult for him, but in spite of this, he is with us. So, and I'm sure his presence will definitely boost the morale of all the coordinators who is working for this project in 8 Northeast states. Thank you, Rishikesh, for extending your support to this project. And we all are working for women of India. And this is FOGSI's ultimate goal, women's healthcare in India. In 2020, FOGSI has started this this program on a bigger way about cervical cancer before WHO and Government of India has signed and declared. And during 2 years on International Women's Day, we conducted a camp, cervical cancer screening camp, pap smear, and all this camp. And in spite of COVID-19, in 4 hours only on that particular day, in both the years, we have screened more than 60,000 women across India. And this boosted us morale of all of us because more than 200 societies participated in this program. But later on, with the advice from WHO, from Niti Aayog, and from Ministry, and from Shankar Narayan and from Partho Banerjee, all advise us to concentrate on one area where the incidence is very high, and that is Northeast is the area in India where the incidence of cervical cancer is very high. So they recommended FOGSI to take care of this, and that is why from this the project was the genesis of this project. And then we have prepared a team. We extend invitation to all those our members who are interested, willing to do work for this program. We made a team of coordinators. We have identified centers. As you mentioned, TOT was conducted. And then the referral centers were also identified, 12 referral centers. Once the HPV test or colposcopy is conducted, if they are positive, where to send them. So referral link were established. And yes, absolutely, you are right. It is, I think, FOGSI's major work is on patients' awareness, patients' education, advocacy, and making them aware and making them willing for these healthcare facilities. And that is, I am happy to know that you are going to work on this. For this project, before 1 week, we also conducted one program for mass awareness. And I hope you are absolutely right, whichever facilities we created, but if targeted population, if they do not reach to the facility and if they are not willing to take the facility, it is of no meaning. And that is why it is a big challenge to all of us, and it is a big responsibility of FOGSI. And it is good that we all are working on it, and it is good that you are concentrating. Your major focus is on it, though you might be confused before 2 months or 3 months, but now you have your focus idea, which is very useful and very important for FOGSI and women of India. So thank you very much, Rishikesh, for this. I am thankful to all the presidents and secretaries of all the societies of Northeast for continuing this program. We distributed posters in the local languages also, and we are continuing with the HPV test screening with their support. And I'm so happy that this is the second web series for making all our 825 FOGSI member working in Northeast to update their knowledge, and this is a refresher course. And this year we are starting with refresher course with the blessings of Madam Musa Saria as the chief guest of this program and Dr. Rishikesh Pai as the FOGSI president. Dr. Gokul Das is the main coordinator of Northeast, and Dr. Priya Ganesh and Bhagya Lakshmi and Dr. Nirja Batla and Dr. Ruchi Patak all are already there, and a big team is there who are expert for this. We have very interesting scientific session. I will not take much time. And thank you very much, all the coordinators, all the delegates, all the faculties for sparing their valuable time, and all the coordinators, Dr. Bhagya Lakshmi, Dr. Prerna, all of you for sparing your valuable time and working dedicatedly, continuous for this project. Rishikesh, we promise you that we will give you a very, very good impact and result during your year for this project.
1 minute, I would like to also tell you, I forgot that we are starting the Badlao clinic. So on 18th of every month, we will have a free checkup. So those who of you, your Gokuldas in the Northeast who want to enroll in the Badlao clinic. So on that day, we will, every, 9th of every month, when I was the Secretary General, we started the Pradhan Mantri Surakshit Matruttva Abhiyan. 9th of every month was started during Alka Kripalain's time. She was the president, and KK Agarwal was the IMA president, and Government of India. Together, the three of us started it. And so I was planning 18th of every month, the free checkup for the, so we are all the time targeting the pregnant women. Now we want to target the non-pregnant. So the NCDs, which includes cancer, thyroid, cardiac disease, diabetes, hypertension, all that. So the 18th of every month, we will have the Badlao clinic where the free, those volunteers who will do the Badlao clinic will do free checkup. And after the free checkup, I'm trying to tie up with 1mg. Already for the Yatra, we have tied up with 1mg where they will do subsidized tests. So after that subsidized test and free checkup, then the patients who come on that day can either get a 20% subsidy for treatment from the same clinic, or they can be referred to the government hospital or for the Ayushman Bharat. So that is what I was planning. And, we need a helpline also. So, how do people know what is available where? How do you know who is doing something in Imphal? So we have to create a helpline. So I'm creating a helpline for FOGSI. So anyone who will, or we can create an app. So all the clinics, Badlao Clinic, and all of you who are doing all this free work can be onboarded. And that can be then the public can access it. Suppose someone is in Aligarh. He wants to know. He will go to the app and say Aligarh. He will type Aligarh. Is there a Badlao clinic there? Yes, there is one Badlao clinic in Aligarh. So he can go take an appointment and he can be serviced. So that is because we want a private. See, government is doing a lot of work. What are we doing? What is the private people doing? We are the people who are the custodians of women's health. But we have to take that initiative and take the initiative forward. That is what I want our FOGSI to do. Thank you.
So really a very good idea to conduct Badlao Clinic, and I request all the delegates, please join for this Badlao Clinic, and whatever little you can do for women of India, you can do through this Badlao Clinic. Please join.
Thank you, sir, so much for your innovative ideas, and Dr. Alpesh sir for guiding us throughout this Northeast project. So again, I extend my heartfelt thanks to Dr. Rishikesh Pai sir for finding time from his busy schedule. So we next go ahead with
Dr. Rishikesh is not only rich in his practice, he is also rich in his CV and in his ideas.
Yes, sir.
Into practice. Rishma always says you have too many ideas, but you need to put them in practice. So, that is where the challenge is.
Implementation is very challenging.
Yeah. But then, sir, not many people have ideas. I know putting it into action is difficult, all ideas, but I think putting them into action. Okay, sir. Thank you so very much. So now we go ahead with the next very, very interesting program that will be Madam's Talks, Dr. Usha Saraya, Madam's Talk. Can I have Madam CV, please? I think she is also very, very well known to the Northeast crowd. So Madam has been the past president of FOGSI, and she's a consultant obstetrician gynecologist.
I think Bhagyam, you can skip this also for me.
Yes, madam. And
The
she has
people
had
have
many
heard.
lifetime achievement awards, and I think is a real inspiration for most of the gynecologists. But she's like a library, I think, to consult whenever any difficult situation, madam will come to help. And many times she'll come to know from someone and call back. Are you having problem in this area? So I'll talk to this person. They will help you. So thank you, madam, again for all the help extended by you for this Northeast project. Thank you so much. Over to you.
Well, thank you very much, Bhagyam, and I'm really happy to have Alpesh. I remember the last 2 years that we have worked, and he has made the Northeast really literate on this subject, and I'm so happy that we are here again to do a refresher course, and I'm sure it will benefit that area, and the figures of incidence and mortality will change. And of course, having Rishikesh with us and with all his multiple ideas and his year, we are looking forward to the year, and I hope go ahead and get a really good lift up for this program of ours. So I wanted to share with you some ideas about the overall subject, the overall how to solve these issues. And the technical part, you have some excellent speakers to in these 2 days, and they will give you all the technical plus points and ways to implement all this. But I just wanted to talk a little on the broad subject. And I'm showing you the map of India because we are all here to do national work. FOGSI is a national society, and today we have joined FIGO and SAFOG. They're also our societies, and we need to work together with international societies also as we solve the problems of our country. So the main thing I wanted to tell you is some statistics. Nobody likes to hear statistics, I know, but in the 25 years from 1990 to 2016, the burden of cancer has doubled. That really is significant. And I just want to cover 1 or 2 lines on this subject, that the breast cancer has increased by 40.7% and cervical cancer has decreased by 39.7%. However, because of the rise in the population, the total numbers of these cases is still increasing. So we do have a major problem with cervical cancer, which we have yet to sort of bring under control. And the third dimension to this is that the mortality of cancer is still very high in our country. We'll come to that, and we need to decline that. And that means our treatment modalities are not reaching the patient in time. So something has to be done. And we have started since 2010 this preventive healthcare and cancer screening with the non-communicable diseases. So I have some views on this, so I thought I'll explain to you. So one thing you have understood, that cancer screening must combine breast and cervical cancer for women. We cannot ignore that breast problem, and we cannot send them somewhere else for it. So we have to take on the early detection of breast cancer and cervical cancer. Oral cancer, even WHO has said they really have no guidelines, no ways of controlling it. And this year, Tedros has said that he will definitely work on it and give us some things about what to do. And this weight chart, BP record, hemoglobin, urine for sugar, in the last 1 year in Kama, we have done my Kama hospital, we did 3 such camps and people were exhausted. Or to do all this in one session, staff is required, more staff is required, and we need better organization because patients should not get tired and exhausted at the end of this session. That way they will never come back. They should be happy, comfortable, go out of the camp smiling and say that we will send our friends for the checkup. So this organizational effort we must work on. And NCDs are not even established everywhere. So they are being established at national, state, and district levels. So we have a long way to go about how to do it nicely and comfortably. Now, screening started after the Second World War. So what were we doing last 50 years? Well, we were very busy doing manpower training of doctors and paramedicals. We had to set up the centers in all the states, which FOGSI has done beautifully. It's all the states we have centers, but districts have to be covered. And this is again a FOGSI initiative of second and third level of FOGSI societies. We have 782 districts and we have some 268 societies or something like that. So Dr. Rishikesh Pai, this is one thing during your year we want to see how many district cities have some FOGSI members and is there a center? And is it viable? Is it working? Can we do something to help that center? And this study of the districts and the societies, we must get it done from our office. Of course, there are challenges to be overcome, but I'm not speaking on challenges. Challenges make you feel depressed and unhappy, and you feel, oh, how can I all the time fight challenges? Let us talk of accelerators. Because accelerators, if we identify, they bring hope and they are put us in a positive mood. So what are accelerators? When you want your car to go fast, you step on the accelerator. But before you step on the accelerator, you have to see that the car is in a good condition, the road is in a good condition, and there's enough petrol in the car or electricity or battery, whatever you are using. So we must do acceleration of our program of cervical cancer control or cancer control, I call it in general. Let's call it cancer control in women because we are not specifying only cervix. So for that, you need people and you need to have a department and you need improvement in patients' lives. So I'm coming to those issues. Now, what we have done in 50 years, if you ask me in one sentence, it is from control of cervical cancer, we have reached the elimination of cervical cancer. And in 51 years, I think that's very good progress for any developing country. And we have today got to a very easy situation where we can now step on our accelerator. So how have we done this? Because what is in the realm of research today, it translates into clinical practice tomorrow. And research has a very far-reaching impact on humanity. So from one test, one PAP test is all we had 50 years ago. We have got multiple tests. We have understood the role of the virus and the HPV. We have even developed the vaccine. And that is the power of science and technology. And Rishikesh has emphasized that we got to use the benefit of technology for our patients. And this is these are just broad views that we have to give our people, that this is how you can step on the accelerator. Now, these 782 districts in India must have a cancer detection center for women. And it may be district hospital, which is in public sector, or it can be a private center. We have access to our own members. They are mostly private practitioners. We can do it on our own. We don't need permissions and permits and this and that, but we have to have some ideas how to do it. Now you just see the current situation that Globocan has given about mortality. In Australia, UK, United States, they lose 1 or 2 patients die due to cervical cancer. And look at in India, which is 12.4. So maybe much higher than what should happen. It is also coming down. I'm not saying we haven't done enough. We have done enough to bring it down. But when the world average is 6.9, we are still 9.2. So we have to work on it. So minimal personnel you will require at each district hospital is the gynecologist, who will be a FOGSI member with a group of theirs, to whom we have access and they have access to us, and we can control things. They have to get hold of a pathology or a laboratory which is existing in that area. They have to find one technician, one nurse, one social worker. This they're capable of doing, and seeing our FOGSI members in all the areas, very, very dynamic and ready to do things. They have access to patients they already have, and they need educational material, which we already have. We have collected in FOGSI. So annual number of cases due are 1,23,900 in our country. This figure has to come down. We have to bring this figure down. And annual deaths are 77. How can we have such a high mortality when this is a treatable disease? And there are cancer centers, there are doctors, FOGSI members who are capable of treating them. So to get started, we must work on a positive note. If any of you in the Northeast who don't have a cancer detection center in your hospital or in your city or in your medical college or whatever, just make a beginning and say, I'm going to get this started. Get a few people to join you, find a local pathologist, HPV lab, a technician, nurse. I'm telling you, technicians and nurses are wonderful people. Given the opportunity, they will replace the doctor also. They can do all this work. Find a room, call it a women's health clinic. We avoid the word cancer detection clinic because people don't want to enter that. You call it Center for Information on Cancer. You call it Preventive Cancer Ways and Means. You can give whatever a positive title. Put some papers, posters. We have them enough, and you can get more. Include list of tests that you're going to do. As Rishikesh said, they must know what is possible. Say simple tests, simple HPV tests, a colposcopy test, whatever. You don't have to work every single day. Once a week is more than enough. 2 hours initially, and as the patients become more, you can have more centers. Give a lecture to your own staff or in your own city to women's groups or something to motivate. Hold group discussions, and press is always there to encourage you. And of course, nowadays we depend on webinars and group things at women's organizations also. You can't just sit there and open that center and not work at it. And how to scale up is very important. You have to scale up, develop your department. First thing to do is get these FOGSI GCPR guidelines. We have worked very hard to prepare them. They're very suitable for Indian conditions. You'll find it's like a menu. You see what is the diagnosis and you see what is the treatment possible, low resource, high resource, everything. So augment and improve facilities. That I'm coming to that also. And it should be very patient friendly. The patient should never go away unhappy from your department. They should go smiling. Train your staff to be welcoming. And educational material is very important because today people want to learn. Everyone wants to learn something new. If you are well organized, get yourself accredited. FOGSI is conducting so many national programs for accreditation. You can easily apply, and FOGSI recognized centers are there. You can get recognized by FOGSI. You can recognize by international organizations. There are many research organizations which are giving you recognition. So there is tremendous possibility. And you can do your own publications, research, and do teaching programs. Now, I'm just showing you this, that how many tests we need. We are not going to be satisfied with just one single test. We are going to give the patient the best treatment. That is another thing I learned from Dr. Pai's presidential address, that give them the best of what is available with technology, with everything. So you need to use many tests to come to the diagnosis also. And this is what I'm saying is the power of research, that every day we have more tests and better tests. And now every woman between the age of 25 to 50 attends an OB/GYN unit at least 4 to 5 times in her life, whether it's for contraception, MTP, delivery, postnatal, bleeding problems, whatever. Now, we can't say that we didn't have access to her to talk to her about cancer awareness and early detection. We have enough access. We have no problem. Only we don't have time. Patient doesn't have time. There is no freedom to discuss a little. But let us change that. That is your badlav again. Let's change that attitude. Let's talk on little broader perspective of her health. She comes to you for maybe for something like a contraceptive or something, but let's talk of her health and say, you must do a cancer detection test. There's so many tests available. You should not neglect this aspect. So Pap smear is a low cost, low technology standalone test. We don't want to get rid of it. We want to use it in our areas where there is no high technology, but we must also embrace high technology. Now you see here what is the incidence of cervical cancer in foreign countries, developed countries, and in our country. They have 5 or 6 cases per lakh. Now it's so easy to treat 5 or 6 cases in a year, isn't it? But here we have a burden of 27, 21, 14. Ours is also coming down. It is certainly coming down, but we have to work on that so that if you have less number of cases, then our cancer hospitals won't be so overcrowded and, inaccessible to everybody. Their cancer patient OPDs will also be manageable. So what are the projects which will help reduce the incidence of cervical cancer? These are our good projects. Age at marriage at 18 years. It's almost, I think, overall accepted by all. This will definitely reduce our incidence. If the girls are educated, that also is very important. If educated girls are there, they will be amenable to all this. And if they are in school, there can be vaccination at school. Most girls drop out only by the time they are 10 years old. That is not good. We have to see that they are in school. We have given free education to the school education to our girls. That will help our project. Bicycles are given to the girls to attend school. I think these are very good social customs. Nowadays, many corporates, many Rotary clubs, they say that who are the rural girls who cannot go to school because there's no transport, give them bicycles. It's a great project, I think, very commendable. Now the girls get some inheritance from their father. So that also helps them. They have at least some bank account, some money. If they are ill, they can go on their own to the doctor. In the past, women could not go to a doctor also. Insurance is available. Cancer policies are very good. How many of us, when we have a cancer patient, we tell them, okay, go get a cancer policy for the rest of your family. It will help you. We have small families, good obstetric care. All these are very, very good projects of ours. We as gynecologists can take pride that we are helping to bring down the incidence of cancer. Of course, to alleviate poverty, better housing and water supply, and create health awareness is all going on. And these are all the United Nations developmental goals. There is no doubt that we must emphasize on them. So implementation is we want to do screening and vaccination together. We want to link it because that way both of them will get benefit. So if a mother comes for Pap smear, you ask her, do you have a daughter? And bring her for vaccination. And if somebody brings the daughter for vaccination, you ask her, what about your own checkup? Are you doing your checkups or not? So I think that is not difficult. So I just want to end on this note that the responsibility for management of precancerous lesions of genital tract rests primarily with the gynecologists, in whom women have full faith and expect guidance from. So this is your additional responsibility. I know our gynecologists are very busy. They are doing so much work in obstetrics, infertility, endocrinology. They have all the time they are working. But please remember, this is an important aspect of life, and give your patients a little time on the guidance in this subject. Thank you so much. And thank you, Bhagyalakshmi, for giving me a little more time to explain all these overview of the project.
Thank you so
Thank
much,
you, ma'am.
madam.
Yes, ma'am.
Thank you so much, madam, for those kind words. I think it was an eye-opener for all of us, because these are small, small things, but then if we take care of this, I think we can go ahead. So, do we
I
have
was
Dr.
thinking,
Nirja with us?
Bhagalakshmi,
Yes, sir.
that Dr. Usha Saraya's idea is, madam, the ideas are very good, and miss, we need to somehow integrate it. So I was just thinking that now once I start sending the SMS for volunteers, there's one company who said that they are going to provide 780 clinics. See, basically what I was thinking in my mind all the time is that we need to take the ownership of the non-pregnant healthy women
Yes, yes.
into our
You're right.
hands. See,
Yeah.
you are the pregnant women, so we are all obsessed with pregnant women.
Yeah,
So
yeah.
let's keep them aside. We have got the non-pregnant. I mean, we are the men. They are, the curative. The API, Association of Physicians of India, are too busy with the curation. Surgeons of India are too busy with the IAP is too busy. So the chunk of non-pregnant women are not being attended by anyone, not even our gynecologists, because we are too busy doing delivery. This is a big area of not only social work but financial gain as well for the hours, because we are now slowly changing. Deliveries are going down, and we need to create a social kind of a system, like the pediatricians do vaccination as a social work as well as a source of income. So one of the things I want, so we need to have an integrated clinic which does adult vaccination program, which does a cancer clinic program, which does a menopause clinic program. So we need to get into the area of preventive health and also the area of NCD. So we need to have association so that we can get trained for diabetes screening. Once suppose there's a diabetes is picked up, we have one consultation by the diabetes specialist. The remaining continuation of treatment can be taken control by the gynecologist. So these are areas which we need to start looking at, so that it not only it will improve the preventive aspect, but it will also create new avenues of practice for our society members. This is what is in my mind, that we must create social work as well as create, because there are 6 pillars, I always say, but the 6th pillar I never verbalize in my talk, because I felt that I may not be looked upon nicely, but that the fact of the matter is the 6th pillar. So we have the academics, the research, the advocacy, the CSR, okay, and the fellowship. But the 6th pillar, which is the most important pillar of a practice, which I also got scared to verbalize when I was talking about my presidential address, and that pillar is the pillar of business development. We need to be independent financially, so to stand our own feet, because then only we can do the remaining 5 pillars of our association. We need to be financially secure, and that is what we also have to give it a thought. This is what I so it's not, see, Alpesh, what I respect you is that you have been a great president. You have continued it, but we as a collective, and this is where we should bring our collective thought together. Next few 5-6 presidents, past presidents, have to start evolving a strategic planning for the federation. What is our strategy going forward for the next 5 years or 7 years? The strategy, when I was IFFS board member, I was exposed to this strategic planning. The planning, we had to pick people like Gokuldas, create a strategy. How are we going to do? Because there is what is known as variegation of thought process in our country. We need to integrate that thought process if we are to make impact on society. Sorry, I'm taking time. I better leave, otherwise I'll derail your program.
Sir, you're muted, sir. Alpesh, sir, you're muted.
Dr. Rishikesh, it's a very important discussion and very important not only for FOGSI but overall country's health also, we can say. I think under one head, prevent the preventable deaths and disabilities. Whichever the preventable deaths, which are the preventable disabilities in women, I think if we concentrate on it, it will automatically include vaccination, screening, everything. And once the once the awareness will be there, lot of work will automatically develop from this social work, which will also help our members in financial stability also. That is a different aspect, but automatically it will be the effect, side effect of this social work if great awareness will be created, and if women of India and girls themselves are aware about their health, then this will be the great service to the nation, and it will also help our members in their practice.
I think Dr. Nirja Batla needs to convince the government to spend more money on awareness program. I always feel even if they spend 400 or 500 crores a year, they do it with all the associations. See, the problem is there's a disconnect between the associations and the government. Every Royal College president is knighted by the Queen. That is the respect they give the association. Has been any of our president been given Padma Shri by the government? That is what the respect. Once we develop that respect for the association can do tremendous work. We are all doing pro bono work. Do we take any money for this work? No, it's all pro bono. Which country in the world does pro bono work? You tell me. No one does it. In fact, they get worried. They say, you do work without taking money? Yes, we do the work without taking money. That is our greatness. When I was a Manyata administrator, they paid me money. I said, I refused it. I donated it back to the federation. I didn't take a single penny because I don't believe in that kind of work. We are all pro bono. And that is what I feel governments have to. And this is one of the important things, Alpesh, we have to. I'm going to camp in Delhi. I'm going to catch that minister. I'm going to go after the PMO. I'm going to tell them, give us the right to do Ayushman Bharat implementation. Give the federation the right to implement Ayushman. Not a single illegal practice will be there. We will control the Ayushman Bharat such that there will be no malpractice. Let them have the confidence in us. We'll do such a beautiful job of implementation. Anyway, that's a difference.
It is in real sense public-private partnership.
Yeah.
If we are involved with respect, with faith, from very beginning, from conceptualization of the idea to implementation, then it will be a great service to the nation, and it will be a public-private partnership in a real sense. And I think you have chosen a right person, Dr. Nirja Batla. She will definitely help you and FOGSI and all of us.
I agree. The professor of AIMS is the most respected professor in the country. And, she has to lead it. She is our bridge between private and public partnership. Anyway, thank you very much. And Madam Dr. Usha Sarya, what a fantastic talk. I've taken a lot of ideas. I'll incorporate them in the Badlao clinic so that we can, make it a good clinic. And I'm going to put you in charge of that project.
No. Don't put me in charge of anything. I'm trying very hard to get out of all my commitments, but I'm there for you. Don't
Thank you. Thank you, Alpesh. Thank you, everyone.
Thank you.
Bye. Bye.
Thank you, Usha ma'am. That was really great. And right from, it was really enlightening to hear you speak, right from prevention of cancer across Indian women, from socioeconomic aspects to upscaling health strategies. You have really assimilated it all towards a cancer-free nation. And very truly said that, ma'am, every gynecologist has an access towards prevention of cancer. We as gynecologists can take this opportunity to treat every client coming to our OPD as a screening technique towards counseling, as well as taking up an opportunity to test her a simple pap smear that can be done for every OPD client. Thank you very much, ma'am, for your enlightening words. I now request our very beloved Dr. Gokuldas sir to kindly address the esteemed gathering. Gokuldas sir is from Simanta Sankar Academy of Health and Sciences, Guwahati in Assam 2020. Sir was a founder, professor, and
I think they know by this time I've been, introduced a number of times.
Sir, sir is my mentor. Sir has been so instrumental in this Northeast Cancer Elimination Program. The dice is all yours, sir.
Respected Usha Saraya ma'am, and respected past president Alpesh Gandhi and Dr. President Dr. Pai, who are very good friends of us, and our ever friendship with Usha Saraya. And I mean, that Usha Saraya has been with the Northeast for a long time. And then Bhagalakshmi has been doing a great work for us. I don't know to give a lecture. What I understand is implementation. Already, Rishikesh Pai has given his thoughts. Usha Saraya has given a lot of strategies. Now, how to implement those in our northeastern states? That's what we have to discuss. And I personally feel that we, the stakeholders of the Northeast, should meet and prepare a go-ahead sign and with Bhagalakshmi. And then that has to be implemented in all the different societies and different clinics. And definitely we have to take it up with the health minister. And
So you are muted, sir. Gokul, sir, you're muted.
I will not. I want to say is we have to make a lot of things have been said by Dr. Professor Rafuzal Saraya and also by Rishikesh Pai and also by Alpesh Gandhi. And
You're muted, sir.
And then we have implemented. I think Dr. Bhagalakshmi will give us some guidelines so that this can be incorporated in all the societies. And we have to meet the health officials, government officials. I plan to meet them in next month. And this month I may be busy because of my son's marriage. So next month we really go ahead, and that's what my plan is. I will not take much of your time. Thank you very much, and then wish you all the best. Okay.
Dr.
I will
Gokul,
take leave because I have some work to do for my marriage.
Dr. Gokulda, thank you for your support. Always you are there to support the project. We are planning to come to Northeast. Probably myself, Nirja, Bhagalakshmi, Priya Ganesh.
Yes. Sure.
You may come to Northeast, and we want to visit as many states, and we want to visit as many as health officials or health ministers in different states.
Definitely, I will do it.
Please plan a calendar or meeting or take their time. We may come after 1 or 2 months because your son is getting married. Similarly, my daughter is getting married on 27 November. We all are busy with marriages of our family members. But after that, I think from January onward,
Sure.
we may find some time where we want to meet health officials in Northeast. We already have prepared advocacy statement of FOGSI, and we handed over it to all the health officials in Northeast, not only in Northeast, to more than 200 health officials across the country about this cervical cancer prevention. So advocacy statement is there, planning is there, pragmatic approach is there. We need to meet them, to convince them personally and to take their support. And I think you may be the most instrumental person. You are most respectable and most person who has maximum contacts, most resourceful person. So please plan some meeting with all health officials for all of us also.
Sure. What do I say? Thank you very much.
Of course, you will be there with us. You will take us.
We'll do that. We'll do that.
Thank you, Alpesh, sir. Thank you for your always innovative and strategical approach strategies. And thank you, sir, for being with us always. We have with us Dr. Nirja Bhatla, ma'am. Dr. Nirja Bhatla, ma'am, is a past chair oncology committee of FIGO, and she had been the vice president-elect of FOGSI and immediate past chair oncology committee FIGO. Ma'am, we are really honored to have you with us. Ma'am will be presenting her view on prevalence of cancer cervix in the Northeast, ma'am.
Hello, thank you for that nice introduction and invitation, and good evening to all the dignitaries gathered here today. I am so sorry that I was late in joining. We were doing a live operative workshop today and I got really late getting back. So we have been meeting many times regarding cervical cancer prevention activities in the Northeast with various people. And I really compliment Dr. Alpesh, who thought about this, and Dr. Bhagya Lakshmi, who was executing it so beautifully, as well as all members. I joined in time to hear Dr. Usha Saraya's talk, and madam, it was wonderful. It was so wonderful because you really broke it down into a very simple sort of a kit that you take these steps and you will reach there. So, it's all right to know the hi-fi and the fancy stuff, but it reminds me of a cartoon which I once saw, which had this person with a chef's hat and a lot of ingredients around saying, I know what I want to do, but how am I to do it? So it's a question of having all the ingredients and then wondering which are the way to do it rightly. And it's so nice when someone with considerable experience in setting up these programs steps it out for you and says, just do this and you'll be all right. And of course, there are always valuable insights to be learned from people who have the local flavor, knowledge of customs, and all of that to add and enrich the programs. But it's great to have these basic thoughts, really. And I completely endorse what Dr. Rishikesh said also about having said a lot about making these efforts to do charity, to make it, I've talked about make your CSR not corporate social responsibility, but your cervical screening responsibility. But having said that, yes, why not? Why should this not be the primary income source for a doctor? There may be doctors who want to do something which is not very taxing. And what can be better than this type of a clinic, which looks at women from adolescence to geriatric and looks at every step of the way to make them lead healthier, richer lives? And people are living longer. Women, as it is, have better life expectancies. So they should live longer with health and quality. So I think it's perfectly good and right to think about how we can. And when we do things in bulk, the costs also come down and it becomes more affordable for everyone. In fact, it's a known fact that in the UK, it was only when the government incentivized the GPs to have at least 70% coverage of cervical cancer in their areas when the real drop in cervical cancer was seen. So money does make the world go round, and we should be quite happy to think about making this a career that can be lucrative. But having said that, let's come back to where we are today with the project. And we have enough data to show that while we have less cancer overall in the Northeast, the report from the National Cancer Registry has come out now looking at all the data between 2012 to 16 in great detail. And while the cancers overall are more in Western India and Southern India and are lowest in Northeast India, but cervical cancer, the highest incidences are actually seen in the Northeast and more so in the rural registries from the Northeast. So I think we have a great thing going here already, in which we have a network of people from the Northeast. We have a system whereby we can access the societies of the Northeast, and we can work together to show. The important thing is that we should be able to show that this is a system that can work and can be replicated. And that is the goal of the project, to say that this is something which is acceptable, which is feasible, which is effective. And if we do this, then we can replicate this in a similar way with the lessons that we may learn from the project here to go into other parts of the country where we want to follow India being a signatory to the WHO declaration. We want to try and transition to HPV screening. We want to see that we promote awareness and access to vaccination. And we do know that the government does intend to launch vaccination once Cervavac is ready with its supplies and is ready to provide a continuous basis supply chain. So that day is also not far. And meanwhile, if there are people who can pay for the vaccine, they should definitely be encouraged not to delay it further. Because there is evidence now from the analysis of the program in UK that the younger the age at which the girls got it, the better was the efficacy of the vaccine in preventing CIN and preventing cancer. So we should promote this information, we should encourage it, and we should take down notes about what worked, what didn't, have experience sharing amongst us, each other, and enrich the services being provided in different states of the Northeast by this via media of our project, which is uniting us with so many societies, FOGSI, SAFOG, FIGO. Everyone is speaking with one voice that we must eliminate cervical cancer. The time is now. So thank you for asking me to be here again and share my thoughts. And thank you for all the good work that is being done.
Thank you, ma'am. Thank you, ma'am. It was always a feast to hear you speak. And what a concept that you have picked up from Usha ma'am's talk, that it is good to know the hi-fi, but then to where to start the basic key, and then we will be there. So we all it is an eye-opener for us beginners, and we'll definitely follow that. And really, truly said, ma'am, every woman has this right to have a better life expectancy and live a better quality life, and that we are the ones, the gynecologists, who can help them do that. Thank you, ma'am, for your words of wisdom. It's really always a feast to hear you speak, and we are really honored to have you amongst us now. Thank you, ma'am. We now move towards as we have taken up this particular spree across the globe, joining hands with FIGO, SAFOG, as well as FOGSI to spread this cancer elimination program across the globe and make this Northeastern India cancer-free. We have amongst us Dr. Alia Aziz, ma'am. She is the chairperson of Oncology Committee, SAFOG, who will be speaking on risk factors of cancer cervix. Can I have ma'am CV, please? Alia ma'am CV, please. Dr. Alia Aziz, she is a professor, education MHPE, and chairperson of Oncology Committee, SAFOG, and associate professor and gynae oncologist, and director of the fellowship program of gynecological oncology, Department of ONG, Aga Khan University Hospital, Karachi, Pakistan. Thank you so much, ma'am, for being here with us in this August gathering, and we are ready to hear your words of wisdom, ma'am. Thank you, ma'am, for joining us. Please, the stage is all yours, ma'am. Alia, ma'am.
Thank you for your kind introduction, and thank you for inviting me for this important webinar as a refresher course. Can you all hear me?
Yes, ma'am, we can hear you.
Yeah, I'm sorry about the technical issue in which you can't see the video, but I would like to share my screen. Okay, so today, on behalf of SAFOG, I would like all of you to, I would like to congratulate you on such an important webinar as a refresher. And I was given the task of talking about the risk factors for cervical cancer. So I'll be talking about what's the evidence about the risk factors. I do not have any conflict of interest. So we all know that when we talk about risk factors, we talk about HPV, and HPV is a double-stranded DNA virus which attracts human epithelial cells. There are about 200 different strains of virus which have been identified. 30 to 40 are the ones which affect the anogenital region, and out of these, 15 to 20 are oncogenic. It is considered the most common sexually transmitted infection. The causal relationship between HPV virus and cervical cancer was established in 1996 when the NIH Consensus Conference was held, and now it is not a mystery that HPV causes cervical cancer. And it is associated as a causative factor in about 93% of cervical cancer and its precursor lesions. So it is a high incidence of HPV virus in cervical cancer. When we talk about the risk factors or the cofactors, we have these few important issues or factors. One is the high parity, use of oral contraceptives, tobacco smoking, immunosuppression, especially with HIV virus, infection with other sexually transmitted diseases, poor socioeconomic condition. They all have been associated to various extent with the development of invasive cervical cancer. So we'll be taking one by one each. So when we talk about high parity, there is an increased incidence of cervical cancer in women with who have given multiple births as compared to women who have never given birth. So those with 3 or 4 full-term pregnancy have a 2.6 times risk of developing cancer, and women with 7 or more births have actually 3.8 times the risk. So high parity is considered as a risk factor. Then we have the long-term use of oral contraceptive, which is a possible cofactor, and it has been suggested that long-term use of oral contraceptives can increase the risk of cervical cancer by up to 4-fold in women with HPV infection. Now, this is a very important topic, and WHO has taken a stand on it, because if you say that women should not use long-term use of, should not use oral contraceptives, then in areas where there is no screening facilities available, this is a common thing which we see in the low resource countries like SAFOG, that screening facilities are not easily available. So should we deny these women oral contraceptive use? WHO has actually developed a board, and they have discussed this issue, and they have come up with the suggestions that women should not be denied use of combined oral contraceptives simply because they are unable to access screening services. Why? Because in these areas, the risk of maternal mortality from non-use of contraception would likely far exceed any additional risk of cervical cancer for most of these women. So this is important for us to understand that yes, we should not be using long-term use of, we should not be using oral contraceptives for long, but we cannot deny the risk. It's also because high parity is considered a risk factor. And this is also not understood why high parity is a risk factor. Some speculations are, these are some hormonal changes because of pregnancy. Some say it is cervical trauma at the time of delivery. So if you balance these, then oral contraceptive should not be denied to any women just because they cannot access the screening facilities. Then we come to smoking. Smoking is strongly associated with development of precancerous lesions or cancer, and it is the most consistently identified environmental cofactors which can influence the risk of cervical cancer. And studies have shown at least a 2-fold risk for current smokers compared to non-smokers. HIV infection is again, women who have currently been infected with HIV are at high risk, are also readily infected with high-risk HPV types, and they are more likely to develop precancerous lesions than HIV-negative women in the same age category. Also, they develop the precancerous lesion more rapidly. So it's not a slow progression as we see in a non-HIV infected. Then we come to the most important cofactor, which is a low socioeconomic status, and it is a risk factor for many health problems, including cervical cancers. Why? Because there is limited income, there is restricted access to healthcare services, there is poor nutrition, there is low level of awareness about health issues and preventive behaviors. And all of these factors can make them more vulnerable to illness and preventable diseases such as cervical cancer. Now, there is some confusion. Some risk factors which were considered as cofactors are actually not a cofactor. Like, for example, age of sexual debut, early age at sexual debut was considered as a cofactor. Lifetime number of sexual partners, history of sexually transmitted infections, they all are linked to the likelihood of becoming infected with HPV, but they are not considered to be cofactors for the progression from HPV infection to cervical cancer. So this is an important concept which we should understand. So to summarize, HPV is the most common sexually transmitted infection in adolescent and young girls and is directly linked to anogenital warts and cervical cancer. Cofactors such as parity, use of oral contraceptives, tobacco smoking, immunosuppression, particularly related to HIV virus, infection with other sexually transmitted disease, and poor nutrition all have been associated to various extents with the development of invasive cervical cancer. Thank you.
Thank you, ma'am. That was indeed a very elaborate talk. And we are really blessed to have you amongst us. And it's really a matter of fact that if we know the risk factors in detail, then we can definitely have a better preventive health for the women of the nation. Thank you, ma'am, for sparing all that time out of your busy schedule. We now move on to our next topic for this academic session today. I invite Dr. Ruchi Pathak, my very beloved friend, Master Trainer, Government of MP Cancer Prevention Program. Dr. Ruchi Pathak, can I have a slide CV, please? Dr. Ruchi Pathak. Dr. Ruchi Pathak is a technical lead of the project Sampurna of UP government and the master trainer of Government of MP Cancer Prevention Program. And she's the district coordinator of Pradhan Mantri Surakshit Matritva Abhiyan Varanasi. And Dr. Ruchi has been the executive committee member of Oncology and Trophoblastic Committee member of FOGSI and has innumerable awards and publications to her credit. I invite Dr. Ruchi to kindly present her deliberation. Dr. Ruchi, are you there?
Thank you for the generous introduction. Very good evening to all of you. And I thank the organizers for giving me this opportunity. And I'll be talking about the principles of VIA and BILI. I'll be sharing my screen. Can you all see my slides?
Yeah. Yes, yes.
Yes, ma'am.
So VIA, we know, is visual inspection of cervix after application of acetic acid with naked eye. It is a low cost and ease of training are merits of VIA as screening at PHC level. The results are immediately available and it is amenable for screen and free approach for CIN lesions. Now coming to the pathophysiological basis of VIA, acetic acid clears the mucus secretions on the cervix. It causes dehydration of the cells and also reversible coagulation of cellular proteins. The normal squamous epithelium appears pink and columnar epithelium appears red due to the reflection of light from the underlying stroma, which is because of the blood vessels. Now, if the epithelium contains a lot of cellular proteins, acetic acid coagulates these proteins, which may obliterate the color of the stroma, resulting in acetovightening, which is seen distinctly as compared with the normal pink color of the squamous epithelium, seen with the naked eye. So, there is dehydration of cells and coagulation of nuclear proteins. The metaplastic and dysplastic epithelium, we all know, have higher nuclear cytoplasmic ratio. Therefore, they reflect more light back to the observer. The subepithelial vessel patterns are obliterated and dysplastic areas look whiter than the surrounding tissues. So, once this is the normal epithelium, and this is the stroma with underlying blood vessels. Now, once we throw this slide, then it is reflected and we see the translucent pink color. But we can see there is increased nuclear protein. So when acetic acid is applied, this nuclear protein is coagulated and the light is reflected from here back, and this light appears white. So the response of to acetic acid of squamous epithelium, there is no change. Columnar epithelium may turn faint aceto-white, and we may be able to see the villi pattern. But the atypical epithelium, we see the dense white aceto-white change. Now, let's come directly to the instruments which are required for doing VIA. So it's very simple. We just need examination table, light source, preferably white source of light, Casco's speculum, instrument tray, distilled water, glacial acetic acid, cotton tip swab sticks, disposable gloves, documentation form and register, and waste decontamination and disposal. Before doing VIA, we need to understand how to make 5% acetic acid. So for this, we need to take, say, if we have to prepare 100 ml of 5% acetic acid, we'll be needing 95 ml of distilled water. Always remember, it has to be distilled water and not normal saline, which we have seen in many places that nurses, they don't understand the difference, and many times they use normal saline for making 5% acetic acid. So it has to be distilled water. And then we add 5 ml of glacial acetic acid. And remember that it has to be freshly prepared every day. The staff preparing the acetic acid should understand that he or she needs to wear the gloves, and it has to be, the amount has to be measured perfectly. So, and it is good practice to add 95 ml in measuring cylinder. Then with syringe we can take out the desired amount of acetic acid, and remember to shake it well. Or what we can do is, first we should add acetic acid followed by distilled water, label the bottle, and the amount which is left after the screening should be discarded. So before starting the procedure, we all understand that we need to explain the procedure to the woman. We need to take informed written consent from her. We take detailed gynecological history. After that, the woman is made to lie down on examination table in lithotomy position. Ensure that the light source is of good quality and it is focused on cervix. We observe external genitalia for excoriation, warts, vesicles, etc. Then gently introduce sterile bivalve speculum and adjust and still retain with screw to obtain good vision of cervix. We inspect cervix, remove mucus using swab. After this, we try to identify the SCJ, squamous epithelium, columnar epithelium, and the transformation zone. So after this, we apply 5% acetic acid with the swab stick for 1 minute. And remember, 1 minute is for complete 60 seconds. It's not a guesswork that, okay, I think this 1 minute is over. So we should remember to have a clock with seconds arm. Then observe transformation zone over 1 minute. Check for aceto-white areas over transformation zone. Note how close to SCJ the area is, how early the aceto-whitening is appearing, its density, and how long they remain. Aceto-white areas, if there is any, then report as positive. If there is no negative aceto-whitening, then it is negative. Or if it is suspicious for malignancy, we report it accordingly. We also observe the intensity of aceto-white lesion, whether it is shiny white, cloudy white, pale, or dull white. The speed with which it appears. It also tells about the severity of lesions. So lesion which appears immediately and stay for more than a minute are more likely to be high-grade lesions. Now we also see the borders and demarcations. So distinct, clear, sharp, and lesions with raised margins are of high grade. Whether lesions are uniformly white or vary in color and intensity. Then note the location of the lesion, whether it is on the transformation zone, near SCJ, And does it occupy part or entire transformation zone? Also note the size and number of lesions. So coming to the interpretation of VIA, so basis the intensity, the lesion can be faint or translucent, or it can be dense as to white change. Now, duration of whiteness may be transient, or it may be quick to appear and last longer. So if when it is transient, it is VIA negative. If it appears quickly and persists longer, it is VIA positive. Now, in VIA negative lesions, we get diffuse irregular margin, whereas in VIA positive lesions, the margin is sharp and distinct. It is very important to see the proximity of the lesion to SCJ. So lesions located far from SCJ and not restricted to transformation zone are negative, while lesions which are close to SCJ or arise from SCJ are VIA positive. So this is just a pictorial description of VIA. VIA negative lesions. So we can see lesions which is far away from SCJ, then faint as to white areas, streak-like as to whitening, line-like as to whitening at brim of endocervix, and dot-like pale areas in endocervix are all VIA negative. So we have seen that VIA negative, there is no significant whitening. The cervix is pale white. There may be faint focal areas away from transformation zone. In VIA positive, there is dense whitening with sharp borders, and one border is within the transformation zone. So these are some physiological conditions which we may encounter while doing VIA. So we can see here this redness is large cervical ectopy with undergoing metaplasia. This is chronic cervicitis with, we can see button-like bluish discoloration. This is Nabothian follicles. Now this is faint whitening at SCJ. We can also notice this transparent whitening of columnar epithelium and the streak-like whitening in columnar epithelium. This is all VIA negative. So we see that no white lesion, Nabothian cyst, endocervical polyp as is seen here, irregular digitating white areas away from SCJ, and streak-like whitening areas in columnar epithelium are all VIA negative. Coming to VIA as positive white lesions. So we may get whitening in cases of squamous metaplasia, in healing or regenerating epithelium, in cases of cervical condyloma, in CIN lesions, and in invasive cancer cervix. This we can see lesions here, 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 and here. Excuse me. As we discussed, VIA positive lesions have sharp borders, as you can see here and here. Excuse me. And suspicious lesions for cancer, we all know there is cauliflower-like growth, which is friable, it bleeds on touch, and we refer these for biopsy for management, but not for diagnosis. Now, just a few images of cervix. This is a normal cervix, which is nulliparous cervix. We can see the pinpoint os here. This is cervical mucus plug. This is the SCJ. This is columnar epithelium. This is squamous epithelium. So now we are discussing about the interpretation of VIA test result. This we can see is a normal cervix. Paracervix, you can see slit-like opening of the external os in comparison to pinpointed nulliparous cervix. This is thread of IUCD. So we can do VIA with IUCD thread in situ. This is squamous metaplasia. We can see here. This is ectopy. So ectopy is eversion of columnar epithelium of endocervical canal to vaginal on the ectocervix. So this is a physiological process. There is nothing wrong in it. And over the period of time, this epithelium undergoes squamous metaplasia. Now, I hope you all can appreciate this aceto whitening here with sharp borders. So this is VIA positive. So this is inflamed cervix. This is red, angry looking cervix. So this is an inflamed cervix. You can see multiple Nabothian follicles here, which is normal. So we don't need to do anything to this Nabothian follicles. We need to leave it as such. So this is cervical polyp, which we encounter, and we can either remove it or we can leave it as such. If it is causing any problem, then it has to be removed. But remember that it should not hide any lesion beneath. So we have to be very careful before giving the result with cervical polyp in situ. Now you can see the arrows. It shows the advancing age of squamous metaplasia in anterior and posterior left. So it is progressing from outside to towards inside the endocervical canal. This is again a VIA positive cervix. Dense, thick, well-demarcated margins. We all can appreciate here. This is Nabothian follicle. This is discharge, curdy discharge, most likely a case of candidiasis. Genital warts can present like this, here and here. You can see this small, flat, dull acetobite lesions. So again, this is VIA positive. Again, this is circumoral acetobiting. This is again a VIA positive high-grade lesion. This is again VIA positive. See, this is Nabothian follicle. This shiny bulge is Nabothian follicle. This is because of the crypts which are covered by metaplastic squamous epithelium. The secretion gets collected here. So remember, we don't need to do anything because the secreting cells, they get damaged because of the pressure necrosis of the secretions. This is again a VIA positive cervix. Again, VIA positive cervix. This is again digitating. You can see acetobiting. So again, it is VIA positive. So you can encounter these kind of cervix very often in cases which are of high grade. So we all can make out that this is a frank cervical cancer. And the growth is cauliflower-like fungating. Again, VIA positive. This you can see there is a hemorrhagic tumor mass in the cervix, so we don't need to do a VIA, and we can directly send her for biopsy for further management. These are all VIA positive cervixes. This is again high-grade lesion, most likely malignancy, invasive, early invasive disease, or maybe frank carcinoma. So normal cervix appears like this, VIA positive is this, and advanced invasive cervical carcinoma we do encounter in our practice looks like this. Now coming to visual inspection with Lugol's ID, we know usually most of the ectocervix and the entire length of vagina is lined with squamous epithelium, which is uniform, stratified, and non-keratinizing. Now, because mature squamous epithelium contains glycogen, it readily takes up Lugol's iodine. So when it takes Lugol's iodine, we call it Schiller's test negative. So, and if it does not take, then Schiller's test is positive. So this is mahogany brown or black color of the cervix, which is normal. Let's see what happens to cervix when we apply Lugol's iodine. So in inflammatory lesions of cervix, we can get this stippled kind of appearance, which shows the infection by trichomoniasis. So again, in trichomoniasis, we may encounter this leopard skin appearance after Lugol's iodine application. And when we get high-grade lesion, you can see there is no iodine uptake, so it is high-grade lesion. And in lesions like condyloma, there may be partial uptake of iodine. So these are some aceto-white lesions, and this after application of Lugol's iodine. This is the practical manual on visual screening for cervical neoplasia. So it has got this beautiful pictorial images, and it is a good practice to have these images in your screening area so that in case of doubt, you can refer to these images. With this, I come to the end of my presentation. Thank you all.
Thank you, Dr. Ruchi. That was indeed very elaborative presentation on the visual screening aspect. You have touched almost all aspects of practical via NVLE procedures as well as the interpretation part. It is really very illuminating for each one of us who is listening and the esteemed dignitaries out here. So we thank you very much for your honored presence, and we move on to our next topic of today's academic session. That is, Dr. Sarita Samsundar has not been able to join us because of some unavoidable reasons. So we move on to the cytology part of from Dr. Subrat Kumar Panda, who will be speaking on Pap smear collection. Sir is the HOD of OBGYN Nigrims Shillong. So we are really honored to have you amongst her, sir. The dais is all yours. Sir. Subrat, sir. So you can share your slides. Meanwhile, sir is having some technical glitch. There are two announcements to make on behalf of Dr. Alpesh Gandhi, sir, and the entire team which has been working for the cervical cancer elimination program in the Northeast. There is a Google form that has been circulated in the WhatsApp group as well. And this form actually is pertaining towards cervical cancer screening practices in our region, that we can know how FOGSI has to intervene and to improve the services that are prevailing already. So please, I will advocate everyone to please fill up this form and submit it by the 7th of November 2022, so that we can improve the way we can intervene to improve the services that are already prevailing in our state and the entire Northeast. So everybody is requested to please fill up that. So we have Dr. Subrat Panda with the Pap smear collection for CA cervix screening. So you're muted. Kindly unmute yourself. Sir, you're muted. Kindly unmute yourself, sir.
Hello?
Yes. Yes, sir. We can hear you, sir.
Okay. Today my topic is Pap smear in carcinoma cervix screening.
So you can put the slides on slideshow, sir.
Slideshow, na?
Yes, sir.
Hey, Baba.
There is a small cup down here. This one. Yes.
Slideshow.
This one, sir. Not the design, the slideshow, yes. Just bring the cursor down near that 62%. Okay. Yes.
Okay. Okay. Good evening to everybody. Today I am going to speak on Pap smear. Before going to speak of this Pap smear, what do you stand for the cervical screening? About the Northeast, I am telling about the Meghalaya. According to the NFIGO 5, the cervical screening of Meghalaya women is just only 0.5%. And all India level, it is 2%. But any one of the screening, only 7% women are covered. Before talking about Pap smear, let me speak about squamous junctions. This is very important. During embryogenesis, upward migrations of the stratified epithelium, the urogenital sinus and vaginal plate replaces the Mullerian ducts. The process usually terminates nearly external cervical loss, that is the squamous junction, that is congenital. When visible on the ectocervix, this squamous junction is pink, smooth squamous epithelium juxtaposed against the red, velvety columnar epithelium surrounding the cervical loss. Age and hormonal status are the most important factors influencing locations of the squamous junctions at birth.
Sorry to interrupt, sir. Slides are not moving, sir.
Yeah, what happened?
Slides are not changing, sir. It is on the first slide itself.
Oh,
So you have to you have to bring the cursor near that 62% battery that you are showing. This cup down there, and you have to click there.
Baba,
or you can just
what
shift on the next button.
Shift on the
next arrow. If you can do that, that also
this
will
one.
keep
This one.
down arrow. If you keep moving the down arrow as you speak.
This one.
Then put the.
So we are having slides of yours, sir.
Okay.
Shall I display them, sir?
You are able to see now?
So we are able to see the slides,
sir, but slides are not moving.
Slides are not moving.
Yes, sir.
There is a slideshow button. This near that 62% charge written there. There is one button. You can just
answer 3. One question 62%. Please
just near this. You can press on the next button also. I think Sahiti, you can share the slides on his behalf.
Okay, ma'am. Okay, ma'am.
Then stop sharing, and then you can share the slides.
Yes, ma'am.
Yes, sir. Subrata, sir. Subrat, sir. Sir, are you there? Hello. Subrat, sir, are you there?
Yeah, I'm there.
Sir, your slides are now visible. They are sharing there on that part, the host. So you can just speak. Yes.
Okay, I can just speak. Okay. Squamous junction is very much important during the cytology. It is visible when visible on the ectocervix. This squamous junction is a pink, both squamous epithelium juxtaposed against the red, velvety columnar epithelium surrounding the cervical os.
Sir, is there any problem, sir? Sir, we can't hear you.
There is some network issue in his area. Subrat, sir. Hello. Subrat, sir. Can we go on to the next speaker? If in case there is some glitch, we can connect with him again.
Okay.
Now, sir, yes. So there's some network issue in your area?
Yeah, maybe. Because I was watching, everything was all right. When I speaking, it is not all right.
Yeah, now you're audible, sir. You can continue.
Okay. Age and hormonal status are the most important factors influencing the locations of the squamous junctions at birth. During the premenstrual year, the squamous junction is located at or very close to the external os. During the reproductive age, the squamous junction is located distance from the external os. In postmenopausal women, the squamous junction is not visible and has receded into the endocervix. I think it's not moving. Okay, this is the squamous junction located on the ectocervix and is fully visualized. This is squamocolumnar junctions not located. I don't think it is. This is the squamocolumnar junction inside the endocervix.
So you can just say next. Once you complete your slide, you can say next,
Okay,
they
okay,
will change
okay.
it.
Okay, please next. The squamocolumnar junctions marks the boundary between the squamous and columnar epithelium. Please next. This is the squamocolumnar junctions. Next. This is the histopathology showing the squamocolumnar junctions. Next. Recent studies indicate that squamocolumnar junctions to be the site of embryonic cells populations with a top-down pattern of differentiations. In this model, the reserve cells are the progeny of embryonic cells with different susceptibility to infections by HPV and therefore involved in malignant transformations. The transformation zone is the site of origins for more than 90% of the precancerous regions, also called squamous intraepithelial regions and cancers. Next. Next, please. Squamous metaplasia. At puberty, the rise of estrogen levels leads to increased glycogenesis of the non-keratinized squamous epithelium. The resultant acidic vaginal pH due to lactobacillus is a stimulus for squamous metaplasia. Next. Next, please. Transformation zone and cervical neoplasia. Nearly all cervical neoplasia, both squamous and columnar, develops within the transformation zone adjacent to the new or current squamocolumnar junctions. Cervical reserve and immature metaplastic cells appear to be particularly vulnerable for oncogenic effect of HPV and co-carcinogens. Next, please. Next, please. This is showing the transformation zone, columnar epithelium, then mature epithelium, which will not be affected by the HPV, and transformation zone with the site for origin of CIN or cancer cervix. Next, please. Cervical cytology. It detects most cervical neoplasia during the typically prolonged pre-malignant and early occult invasive phases when treatment outcomes are optimal. Conventional glass slides, traditionally called PAP or Papanicola's smear or liquid-based PAP tests, are considered equally acceptable or screening by current guidelines. Please next. Next, please. History. Introduced in 1940, cervical cytology has never been evaluated in the randomized control trial or mask trial. However, countries with organized screening programs have consistently dramatically declines in both cervical cancer incidence and mortality rate. Please next. Next, please. The PAP test specificity is around 98%, but sensitivity limited to 45 to 65%. This imperfect sensitivity is balanced by recommendations of repetitive screening throughout women's life. PAP test has lower sensitivity of detections of adenocarcinoma than squamous carcinoma and their precursor lesions. Next, please. Performing PAP test. How to perform a PAP test? Patients should abstain from vaginal intercourse, dowsing, vaginal tamponade, and intravaginal medicine or contraceptive creams for a minimum 24 to 42 hours before the test. Treatment of the cervicitis or vaginitis prior to PAP testing is optimal. However, PAP testing is not deferred due to unexplained discharge or unexplained discharge or bleeding, as there may be signs of cervical or other genital tract cancers. Please next. Please. Necessary information should be taken before getting the PAP smear. The appearance of the cervical squamous cell varies throughout the menstrual cycles and hormonal status. Thus, clinical information adds accurate PAP interventions and includes LMP, current pregnancy, exogenous hormone use, menopausal status, complaints of abnormal bleeding, prior abnormal PAP test results, use of intrauterine devices. Please next. Performing PAP tests, speculum placement should be as comfortable as possible a thin coating of water-based lubricant can be used on the outside of the speculum blades without compromising pap test quality or interpretations. Touching of the cervix prior to age dysplastic epithelium may be removed with minimal trauma. Next, please. Sampling of the transmission zone at this squamous junction is paramount to the sensitivity. 3 types of plastic devices are commonly used to sample the cervical smear, that is spatula, broom, and brush. A spatula predominantly samples the ectocervix, and endocervical brush samples the endocervical canal and is used combination with the spatula. A broom samples both endo and ectocervical epithelia simultaneously can be collected. That is usually preferred in case of liquid-based pap smear. Next, please. Next. This is spatula, this is brush, and this is the broom. Please, next. Next, please. Spatula is oriented to best fit the cervical contour, straddle the squamocolumnar junctions, and sample the distal endocervical canal. A clinician firmly scratches the cervical surface, completing at least one full round. After spatula sample is obtained, the endocervical brush with its conical shape and plastic bristles is inserted into the endocervical canal only until the outer bristles remains visible just within the external os. This prevents the sampling of the lower uterine segment cells, which can be mistaken for atypical cervical cells. This is next. The brush is rotated only 1/4 or 1/2 turn and used after the spatula. Broom devices, 5 rotations in the same directions, not in the reverse directions. Reverse directions lost the cellular material. Please, next. Next, please. Cytology collections, conventional. Conventional slide collections require special care to avoid air drying, artifact, leading cause of poor slide quality. The spatula sample is quickly spread as evenly as possible over 1/2 of the glass side. The endocervical gloss is firmly rolled over the remaining area of the slides, with fixation is quickly carried out by spraying from distance of 10 to 12 inches or immersing the slides in a fixative. Next, please. This next, because this will be spoken by my next speaker. This is next. Next. Please, next. Before that. Before that, limitation. Before that, limitation. The limitations of the pap smear is inadequate collections, sample preparations error, and possibility of inadequate microscopic examinations. Next. Please, next. Benefits. For the any screening test, there should be benefits, harms, and cost effectiveness. Benefits, really there is benefit there because you can diagnose the precancerous lesions, and harm is that you will get that result after long time. Then there will be psychological trauma, or when the results will come, the woman will be worried and she may be referred to the colposcopy. That will be psychological effect up to the woman. Then cost effectiveness of the pap smear, it is really cost effective for the Indian society. For accurate diagnosis, quality control is essential in cytological screening. For reducing the incidence of the false negatives, the cervical smears need to be analyzed twice or thrice by at least 2 pathologists. Lots of time and efforts of trained pathologists resulting in delay in diagnosis. This delay in diagnosis lead to automated pap smear screening devices that Cybest and FOGSI that is not commercialized till now. Pap test with artificial intelligence, that is AutoPAP, and pap smear analysis tool that is yet to be established. I think this is the last. Thank you.
Thank you, sir, for that elaborate talk. And you have covered every aspect of the pap smear collection. We are really honored to have you amongst us. We have now amongst us a very pertinent speaker, Dr. Debobrata Merban, sir, from BBCI Guwahati. He is HOD Gynec Oncology from B. Barua Cancer Institute. Sir is the professor and HOD of Gynecology, B. Barua Cancer Institute, and has almost 36 indexed publications under his credit. He has received the Best Paper in Oncology Award at the AICOG 2013 at Mumbai, and he has a spree of training sessions and awards for his credit. We are really honored to have you amongst us, sir. Sir will be speaking on LVC.
Okay, thank you, Prerna. Am I audible?
Yes, sir.
Yeah, can I share my screen?
Yes, sir. Yes.
Okay. Is it okay?
Yes, we can see it. Put it in the
Just a minute.
slides.
Full screen. Is it okay?
Yes, sir.
Yeah, okay. So at the outset, I would like to thank Alpesh Gandhi sir and Bhagyalakshmi ma'am for taking this initiative for eradication of cervical cancer from this part of the country. And I also like to thank Gokuldas sir for taking this initiative, taking this program as a lead from this part of the country. And also all the other speakers who have done a wonderful job today. So my topic is basically liquid-based cytology, LBC. So as has been already discussed for my previous speaker, you know, cervical cancer is not a disease which comes in days or years, days, months or years. It takes decades to develop. And during this phase, it passes to various phases of precancerous phases, and which can be detected by means of very easily performed tests like the pap smear, the VIA, the colposcopy or HPV. So now today I'll be speaking on LVC, liquid-based cytology. So basically, you know, LVC literally means study of the cells through a liquid medium. So LVC represents the first major technological advancement in cervical cytology. Initially, as you all know, that's conventional smear was developed, and now most of the centers would like to do an LVC because it has got a lot of advantages, which I'll be speaking in the subsequent slides. So LVC-based preparations have largely replaced, as I've already told, the conventional smears. So now if you go back to the history, you see there is a pilot study which was conducted in England in the year 1990s, where they found that when they performed LVC, the inadequacy rate has dropped down from 9.1 for the conventional smear to around 1.6% in the LVC. So there was a great difference. Scotland was the first European country to integrate LVC in an organized screening program, where they have done 70,000 smears concerning 3 centers, where the rate of inadequate smear dropped from 7% in the country at that time with conventional smear to 1% with the smear in the liquid medium. That is why it has come up in such a big way. So now what are the different types? FDA as of now has approved these 2, which are mostly used wherever it is used. So these are basically sure prep and the thin prep. So I'll give you a little idea about what are these 2 things. So now, what are the requirements for LVC? Unlike the CBC, almost the requirements are almost the same. You need the up to the speculum, the brush. Now, here only difference is that instead of the slide and the fixative, we use a liquid media to transfer these cells which have been collected from the cervix. So this is the smear. This is the broom which is used for the liquid-based cytology. Here we don't use the IR spatula. Here we use this sort of a broom. And the thing is that this broom, if you see it, this broom, if you magnify them, you will see that one end is like the flat, other end is like this. So this is the shape of D. That is why, and the liquid media, if you see, this is sure prep, how it looks like. This is thin prep. So I'm showing this to you because there is some difference when you collect the samples and send it to the lab. You know, and how you collect the sample, the cervix, as you have, it is exposed, good light source. Now you put this cervix, the broom, the elongated tip inside the canal, and then rotate it in the clockwise direction. It is said you should always rotate this in the clockwise direction because, you know, as I've already told in my earlier slide, this shape is like a D. So the flat portion of these bristles will touch the cervix when you rotate it in the clockwise fashion. If you rotate in the anti-clockwise, the D portion will rotate, the number of cells will be less that is collected. So you rotate it in five circular circles in clockwise fashion, and you transfer the bristles. The broom is detached from the handle and put inside the container, liquid container, and it is just sent to the laboratory after proper labeling. And sometimes in some patients, there is a pinhole os. When this broom does not go inside, you can take one extra sample by the help of using this cervical brush, endocervical brush. Now, this is how you do in the sure path system. Now, suppose you have generally what we do, we ask the patient to get this liquid media, or you at the hospital where you're working, you will have this in the lab. Either you will be provided the sure path media or a thin prep media. If it is a sure path media, this is how you collect. You separate the broom, you put it inside, and close the cap. If it is a thin prep media, thin prep liquid media, what you do, same broom is used, you rotate it over the cervix, take out, and you put the broom inside the liquid media and just dab it in the bottom of the broom for 4, 5, 6 times, and just discard the brush. Here you don't detach this. This is the actually difference which has been explained, which has been shared by the thin prep media people. So now this is basically the methods, materials, and how it is used. So now, once you have taken the smear, you send it to the lab. Now these two systems, sure path and thin path, the preparation of the slide is different and is done by different methods in these two systems. In the sure path, they do it by centrifugation and sedimentation through a pressure gradient. And in thin prep, filtration and collection of vacuum packed cells on the membrane and transforming to slide. I'll show you how it is done. So this is basically the sure path system, and this is how the thin prep system looks like. So as I was told, this is a thin prep system. There they say it is the filtration technique. Here what happens is that this is how the vacuum is created here, and all the cells are sucked in this area where a filter is attached. So all the cells are get attached to this filter membrane, and these cells are then transferred into the slide. So this is how the thin prep, in the thin prep method, the slide is prepared. And the sure path method, the cells are rotated, and because of the centrifugation effect, it goes down and it is collected in a slide by the sedimentation process. So this is the basic difference between these two processes. And other difference is that in a thin prep, the area is around 20 mm, the slide dispersion area, the slide and actual cellular area in the slide. In the sure path media, it is 13 mm. And it is very uniformly spread, all the cells. So now if you see the difference, there is some difference in the preservative medium. Then thin prep, it is a methanol based. In sure path, it is ethanol based. Here, as you see, thin prep, there is no vortexing, no gradient centrifugation. Here, filtration technique is used for preparation of the slide. Here, by vortexing and gradient centrifugation, which I have already told, the slide is prepared by this method. So now, what are the advantages of LVC? You know, in LVC, the cellular yield is very high, and it removes the air drying artifacts, which is generally the conventional smear. Then you have this cell overlap. All these things are not there in the LVC. It is basically a monolayer cell distribution, and it is homogeneous, well distributed, and cell and sample, and it is reproducibility. Once you collect a sample, that solution can be stored for 3 months for the sure path, and in the thin prep for 3 weeks. So this is how you can preserve it, and any time if somehow your test goes wrong, you can always reproduce that. You can always prepare another slide by that sample, same sample. And less time consuming to screen, going to the smaller area and well-defined screening area. As I was told, 20 mm area has to be screened, and in sure path system, 13 mm area where the cells are evenly distributed. And it is very comfortable for the pathologist to report this slide LBC system. And it is easier to interpret, as I've already told. And there is apart from doing your pap smear reporting, you can also use this sample for performing some ancillary tests like the HPV test, and also immunocytochemistry as P16 or Ki67 can also be done from the same sample. Now, cells can be kept, as I was told, for in the thin prep preservative. It can be stored for 3 months and sure prep for 3 weeks, respectively, at room temperature. And another important thing is that advantage is that it can be automated. Nowadays, computerized automated screening devices are available, which are programmed, which has programmed algorithm to locate and mark abnormal cells, making screening less tiresome and more accurate. And automation may also increase productivity. So, if you are using automation, then LBC is the way to go. So if you, as I've already told, this is how that practically how the slide looks like. This is how a conventional smear looks like. This is how beautiful the LBC slide looks like. An advantage I've already told, you can preserve it for 3 months or 3 weeks. In other case, you can do pap smear, you can do a HPV test from that same sample, and you can do PI16 or Ki67 from the same sample. So this is the advantage. Some disadvantages are there. Basically, the architectural pattern may be disrupted with breakage of papilla, cell groupings, and slightly more discohesion may be there. But these are not serious things. It can be easily ignored. And cytology alterations include smaller cell and nuclear size, and background material sometimes may be lost, reduced, or altered. But this doesn't have hamper in the reporting system. So now, adequacy, specimen adequacy. As you all know, Bethesda system, if you see the Bethesda reporting system, first line that is written is whether the smear is adequate or not. So now this is important. When we say it is satisfactory or when it is say it is unsatisfactory, means the adequacy. So one important thing is that cellularity. It is said that in liquid-based cytology, at least 5,000 squamous cells should be there to say that this specimen is adequate, the smear is adequate, and in conventional, at least 8,000 to 12,000 squamous cells should be there with the presence of endocervical cell, at least 10 in both the system. Then sometimes there may be off-carrying factors like blood and all those things. Then again, we write that it is inadequate smear. And sometimes the slide may be broken, damaged, or unleveled slides. So these are the way they think. These are the certain situations when they will write that it is an inadequate smear. And as I've already told regarding the AI-based cervical cancer screening, this is how it is done. Basically, it is an advanced image processing and machine learning algorithm. It screens out almost 60% of the negative cases. You give the slides, all the normal slides, negative cases, it screens out automatically, and it detects 80% of the positive cases with 93% accuracy for high-grade lesions. And as I've already told, in the Bethesda system of reporting, you will see that there is a column where it is written computer-assisted interpretation of cervical smear. This, if case examined by an automated device, it has to be mentioned in the Bethesda system of reporting. So what is the end result? After doing all these things, this is how beautiful the slide looks like. This is how clear the slide looks like, and it becomes really an easy job for the pathologist to reach the pathologist to identify and to report. This is how it looks like at the end of the day. So if you see here, this is how the smear looks like, slide looks like, and this is how under the microscope looks like in a conventional smear, and this is how the slide looks like in the LBC and in the under the microscope. So to conclude, if it is a HSIL, there is equal sensitivity and specificity between the both the system LBC or conventional smear. But the thing is that it is the ease of doing things. Reduced unsatisfactory smear with LBC is technically easy. Sample collection is very easy. Decreased turnaround time and increased number of cases being reported by the pathologist. And sample preservation is possible, which I've already told. And ancillary tests such as immunocytochemistry and HPV is possible with the same sample. Thank you so much for giving this opportunity. Thank you.
Thank you, Dada. That was really indeed a feast to hear you speak always, and such an elaborate and definitive talk on LBC. I think all dignitaries have been really benefited with your presentation. Moving on to the next academic talk is Dr. Jyoti Meena, She'll be speaking on interpretation of cytology report, and she's Associate Professor OBGYN AIMS New Delhi. And she has almost 30 publications in national and international journals and has been the coordinator for drafting FOGSI CGPR screening and treatment of pre-invasive lesions of cervix and HPV vaccination. Thank you, ma'am, for being with us. The stage is all yours.
Thank you. I would like to thank the organizers for giving me this opportunity. I will be sharing. Can you see my screen?
Yes, ma'am.
Okay, I will do the slideshow. So the PAP, how to take a PAP smear and LBC is already been discussed by Dr. Subrata Pandey and Dr. Devabrata Verman sir. So now I will be discussing about the how to interpret a cervical cytology. So as we know that the cervical cytology is screening, it utilizes cervical cytology, which can be a PAP or LBC test or an HPV test. Results from these tests, along with the patient's past results, if it is known, are used to guide for further evaluation, like colposcopy or directed biopsies or further treatment if required. So the terminology for reporting cervical cytology is standardized by the Bethesda system. This system provides a framework for consistent interlaboratory terminology for reporting cervicovaginal cytology specimens. This system was first introduced in 1988 and it was revised in 1991, 2001, and 2014. So currently the system that we are using for reporting is the updated 2014 Bethesda system. So it is, while reporting a cytology report, it is very important to know what are the components to be reported. First and foremost is the specimen type, the adequacy, general categorization, the interpretation of the results. If any ancillary testing or automated review has been done, then it should be mentioned, and educational notes and suggestions by pathologists, if any. So coming to this, first important is the specimen adequacy. It is an important component of the Bethesda system, as it has already been beautifully described by Devabrata sir. I will just like to highlight what do you mean by a satisfactory cervical cytology. It means that there are adequate number of well-visualized or preserved squamous cells. So in a conventional smear, there should be minimum 8,000 to 12,000 cells. For LBC, there should be minimum of 5,000 cells. But if the patient is a post-hysterectomy or postmenopausal with atrophic changes, or a patient who has undergone chemotherapy or radiotherapy, even cells less than 5,000 can give a satisfactory smear. Now, what is an unsatisfactory smear? There is a scant cellularity, or more than 75% of cells are obscured by inflammation, bacteria, or interfering substance like lubricants and blood. Or it can be unlabeled or a damaged vial or slide. So it is very important to mention if the smear is unsatisfactory. So what happens when we come across an unsatisfactory smear cytology report? So if it is unsatisfactory, review HPV report if it is available. If it is negative, then return to a routine screening. If it is positive, then follow the screening protocol of FOGSI GCPR. If the HPV test is not available or patient is less than 30 years, then it is advisable to report the cytology in 2 to 4 months. If again it is unsatisfactory, then do a colposcopy. If it comes out to be more than or equal to SCAS, then follow the screening guidelines of GCPR for SCAS. Or if it is negative for intraepithelial lesions or malignancy, then routine to a routine screening. Besides this, if you think that the patient will not come for a follow-up or will be lost to follow-up, then a VIA test can also be done. So coming to the interpretation of the results, what are the various interpretations that we get when we send a cytology? So this is the frequency of the Bethesda system categories, which we get on PAP, or the rate of high-risk HPV positivity. So if there is a 94% frequency of getting a NILM on cytology, 3.6% SCAS, LCIL 1.7%, and high-grade lesions 0.3%. So if we look at the interpretation, first is the negative for intraepithelial lesion or malignancy. What does it mean? It means adequate squamous cells in absence of an intraepithelial lesion or malignancy, with or without presence of non-neoplastic cellular variations, which means there can be presence of squamous metaplasia, keratotic changes, atrophy or pregnancy-associated changes. There can be changes, reactive cellular changes related to inflammation, radiation, or presence of intrauterine property device. Or there can be glandular cells post-hysterectomy in post-hysterectomy patients. Or there can be presence of organisms. When we take a smear, there can be findings can be of, along with this can be presence of Trichomonas vaginalis or fungal organisms like Candida, or there can be shift in the flora which is suggestive of bacterial vaginosis. Or there can be finding of endometrial cells in patients more than 45 years old. So what is these endometrial cells? So if they're the exfoliated endometrial cells, there is a normal finding in patients with reproductive age group. However, if a postmenopausal woman cytology report is showing presence of endometrial cells, this should be considered abnormal and it warrants further investigation. Therefore, in the Bethesda 2014 updated classification, this benign appearing endometrial cells should be reported in women more than 45 years of age. Now coming to the epithelial cell abnormality, there can be, we will be discussing about the squamous cell abnormalities and the glandular abnormalities. So coming first to the squamous cell abnormalities. Among the squamous cell abnormalities, there are atypical squamous cells. What does an atypical squamous cell mean? There is cytologic changes in the squamous cells, which are suggestive of a squamous intraepithelial lesion, but qualitatively or quantitatively, they are insufficient to, for a definitive interpretation. So for quality assurance measure, we take the ratio of these atypical squamous cells and the squamous intraepithelial lesion, which is a ratio of 1.5:1. So what is the meaning of this SCS in our cytology? This is the most common cytologic abnormality, and it can be seen in about 2.8% of cervical cytology in women who are more than 30 years of age group. The prevalence of HPV positivity with SCS cytology is seen in about 1/3 to 2/3 of the patients. However, it carries a lower risk of CIN3+. So these SCS cells, they resemble superficial and intermediate cells. And as you can see in this picture, the nucleus is 2.5 to 3 times increased in size as compared to the normal nucleoli. And besides this, there can be sheets of parakaryotic cells with dense eosinophilic cytoplasm with the relatively irregular nuclei, which differentiates the SCS from L cell. So what happens that if we find SCS in a patient more than 30 years? So if we encounter this problem, then either we can do a triage with HPV test. If it is negative, then return to a routine 5-year screening protocol. If it is positive, go for a colposcopic plus-minus biopsy. If it is normal, then advise co-testing or HPV test at 1 year. And if it is abnormal, then follow accordingly. Or we can go for a cytology at 1 year. If it is negative, then return to the routine 3-yearly screening. If it is SCS or LCIL, then go for colposcopy plus-minus biopsy and treat accordingly. If it is normal, then cytology at 1 year. If abnormal, then follow the guidelines. Or if the patient is non-compliant, then we can directly go for colposcopy or VIA with or without biopsy. So this is also an option if you think that the patient will not come for a follow-up or is a non-compliant patient. Now, LCIL cytology is seen in around 0.97% of the women who are more than 30 years. And the LCIL is associated with a high rate of HPV positivity. Even the SCS LCIL triage trial, it observed that HPV positivity rate is seen in 80% of women with LCIL cytology. So this LCIL, it is caused by a transient self-limiting HPV infection that usually lasts less than 2 years. However, if there is a persistent infection, then it carries a high risk of progression to neoplastic transformation. So HPV positive LCIL cases, they are associated with higher immediate risk of CIN3 as compared to those who are HPV negative. The immediate risk of CIN3, it is regarded as the most relevant determinant for indicated clinical intervention. So this table shows immediate risk of CIN3 among different Bethesda system categories. So if it is a negative NILM cytologic interpretation within HPV positive, then there's 2.1% risk of immediate risk of CIN3. And if it is SCS with HPV positive, 4.4, and this gradually increases as the abnormality increases. So with highest in seen with high-grade squamous intraepithelial lesion. So now what is, if we see at this picture that this is a low-grade intraepithelial lesion cytology, here we can see the most characteristic feature is the coilocytes. So what are coilocytes? They show a resinoid nuclei with sharply delineated perinuclear cytoplasmic clearing with irregular outlining. And it also includes focal angulation. Besides this, binucleus and multinucleation is also frequent. Besides this, nucleus is enlarged to 3 times the normal size with nuclear hyperchromasia and nuclear membrane irregularities. So now if we find a cytology report of LCL in a woman more than 30 years, so what should we do? Either we can go for HPV triaging with HPV test. If it is positive, go for colposcopy in biopsy. If it is negative, then co-testing at 1 year. If the cytology and HPV both are negative, then co-testing at 3 years. If cytology is ascus or HPV is positive, then go for colposcopy and biopsy. Or either we can go directly for colposcopy with biopsy, and then we can manage accordingly. If the women is less than 30 years and the cytology is showing ascus or LCL, then what to do? So in these young patients, as the HPV positivity is already high, so we can go for a repeat cytology examination annually twice. And if it is comes out to be negative, then repeat cytology at 3 years. If it comes out to be more, ascus or more, then colposcopic directed biopsy is plus minus biopsy is required. If it is normal, then repeat cytology at 1 year, or if it is abnormal, then follow accordingly. Now, if we come across atypical squamous cells that cannot exclude HCL, that is SCH, then here we can see that the rate of HPV positivity in such women is as high as 67%. So there is no requirement of HPV testing because it will not affect the management of the patient. However, if these women, they should be evaluated by colposcopy with a special attention should be given to adequate visualization of the transformation zone, and endocervical curettage should be done. So in the atypical SCH, there is scant atypical cells, and these cells resembles the parabasal and the basal cells, and they include 2 categories. Either there are small cells with high nuclear cytoplasmic ratio, or they can be seen as a crowded sheet pattern where there is loss of polarity and they are difficult to visualize. So this is how we'll see on the slide. Now coming to the high-grade squamous intraepithelial lesion, the incidence of finding this in cytology report is approximately 0.21%. However, the women who have cytology report of HCL, they are at a substantial risk of developing high-grade CIN and invasive disease. Therefore, they need further evaluation. And there's no role of HPV triage in this group also, because the HPV positivity is as high as 89 to 97%. So high-grade intraepithelial lesions, they are smaller squamous cells as compared to LCL, and they occur singly or in sheets or in a syncytial-like aggregates. That is, there is hyperchromatic crowded groups. There is very high nuclear to cytoplasmic ratio. There is nuclear hyperchromasia with irregularities also seen. Now, if a woman less than 30 years have a cytology report of SCH or HCL, and is desirous of pregnancy, what should we do? We should go for a colposcopy plus minus biopsy because it is a high-grade lesion. If there is no CIN 2 or 3, repeat the cytology and colposcopy 6 monthly for 2 years. If the HCL is still persisting after 1 year, then cervical biopsy should be repeated again. If there is no high-grade abnormality in the cytology and colposcopy after 2 years, then you return to the age-specific routine screening. If after HCL is persisting for 1 year and we do a cervical biopsy, there is no CIN 2-3, then 6 monthly follow-up should be done. But if the high-grade variety SCH or HCL is persisting for 2 years, then a diagnostic accessional procedure should be done for these patients. If this is encountered in women more than 30 years, then colposcopy with cervical biopsy and endocervical assessment should be done. It should be mentioned whether the colposcopy was adequate, whether entire transformation zone was seen or not. If it is less than or equal to CIN1, then either we can go for an ablation and follow up annually with co-test, HPV or cytology, or co-testing can be done at 1 year. But if it is CIN 2 or 3, then leave or ablation of the transformation zone is done, that is see and treat approach, if the patient is eligible for see and treat approach. But if colposcopy is inadequate or transformation zone is not completely seen, then a diagnostic excision procedure, that is a conization, should be done and should be treated according to the findings. Now coming to the glandular cell abnormalities. So when these abnormalities are present, it should be noted whether there are changes favoring neoplasia or not. The incidence of these typical glandular cells is about 0.1 to 2.1%. But these cells are associated with pre-malignant or malignant disease in 30% instances in women who are older than 40 years. So while reporting glandular abnormalities, one should be specific whether they are atypical, not otherwise specified, and should be categorized by the site of origin, whether they are endocervical, endometrial, or the glandular. Or they are atypical cells which favor neoplasia, where we can see nuclear atypia, nuclear elongation, and quantitatively and qualitatively they are insufficient for diagnosis of in situ or invasive endocervical adenocarcinoma. Or there is another variety, that is endocervical adenocarcinoma in situ, where nuclear crowding, enlargement, and hyperchromasia is seen, and there is apoptotic bodies and mitotic activity in a clean background. So all the women with atypical glandular cell category, except those with the AGC endometrial cells, they should be evaluated with colposcopy and directed cervical biopsy along with endocervical sampling. And endometrial sampling should be done in women more than 35 years or even in younger if they are at risk of endometrial neoplasia. So if there are atypical endocervical cells, go for colposcopy and biopsy, and endometrial and endocervical sampling. If there is no CIN2 adenocarcinoma in situ or cancer, then co-test of cytology at 1 and 2 years to be done. If both the tests are negative, return to routine screening. If any test is positive, then repeat the colposcopy and biopsy. If it is more than CIN2, then follow according to the CIN management. If the report is atypical endometrial cell, then endometrial and endocervical curettage should be done. If there is endometrial pathology, manage accordingly. If there is no endometrial pathology, do a colposcopic and biopsy. If it is normal, return to age-specific routine screening. Otherwise, follow according to the abnormality. Now coming to those favoring neoplasia or with adenocarcinoma in situ. If this is the finding, then go for colposcopy plus endocervical and endometrial sampling. If endometrial pathology, treat accordingly. If there is endocervical pathology, a diagnostic excisional procedure, that is conization, should be done, where you need to take an intact specimen with non-fragmented margin, and depending on the extent of the disease, the surgery should be done. If both endocervical and endometrial sampling is negative, then one has to evaluate for ovarian and fallopian tube pathology. If any pathology is detected, then treat accordingly. If no pathology is detected, then conization should be done and treatment should be done accordingly. So to conclude my talk, while reporting a cytology, 2014 Bethesda system is followed. Important components should be documented in the reporting. ASCUS is the most common cytologic abnormality. LCIL with HPV positivity increases the immediate CIN3 plus risk. SCH and HCIL are associated with high HPV positivity and thus needs evaluation by colposcopy with special attention given to adequate visualization of transformation zone and endocervical curettage. And in cases of glandular cell abnormalities, endometrial evaluation is of utmost importance. Thank you.
Thank you, ma'am, for that elaborate presentation. It was really, really beneficial to all our dignitaries. And we come to an end of this refresher course session. By this time, we are late by an hour, by half an hour, but that is really very, all the talks were very crisp and pertinent. And we really thank each of the speaker here. Bhagya ma'am is there. Ma'am, you want to speak something? Yes, we really thank each of our esteemed speakers and honorable dignitaries to spare this time for us today for this refresher course, and starting from the strategical importance of planning for cervical cancer elimination to the socio-economic strata and the statement advocacy statements, from visual screening to cytology, everything has been covered in this just 2-hour duration. So this is a huge task that has been done today. And thanks to all our faculty members for sparing this time for us. And this free for cervical cancer elimination in the northeastern region will be carried on, and we'll having next session tomorrow at 4 p.m. So I request everyone to please join tomorrow as well. And this is a visionary. This has been taken ahead by Dr. Bhagyalakshmi and the entire team. So we are having a difference of the incidence of cancer. If we are as gynecologists, if we reduce that, that will be really a boon for really thank each one of us. Bhagya ma'am?
Thanks. Yeah, thanks so much, Prerna. It was really a pleasure, and thanks for always your unconditional support and help always. Thank you so much. So I thank all the faculty from the core of my heart for having found time for this program. So really, Jyoti, Dr. Debrat, Dr. Subrat, who are here. And tomorrow we look forward to more and more video presentations of all the procedures. So we'll back at 4 p.m. tomorrow. So request all our participants to join in time. And just taking a one word forward from Dr. H.D. Pai's talk, he thought that actually, in spite of doing all CSR activities, we should also be business entrepreneurs. And I think screening for cervical cancer is the biggest entrepreneurship that is going to happen in the coming few years. So people who start screening will get huge number of cases, and I think that's going to be a gold mine. So don't ignore cervical cancer screening thinking that it's not my cup of tea, but that will really fetch you a
Primary
lot of revenue. Okay, thank you so much, and a very good night to all of you. And thank you so much. Thank you. Dr. Jahar is also here with us. So thank you so much, and request your postgraduates also to join. Actually, they are the main ones who will be implementing many things when they once come to the field of work. Okay, thank you, Prerna. Please rush. She has to go to the IAG, Yuva IAG, and enjoy.
Okay, ma'am.
Thank you so much.
Thank you. Bye-bye.
And thank the team of Shield Connect. So, and all these recordings will be available on the Shield Connect. So from Shield side, anyone you want to tell the address exactly where this will be available, all the recordings that we have done?
We will be sharing this link also, ma'am, in tomorrow's webinar.
Okay.
Okay.
Thank you.
Thank you.